الله وبركاته. Finally, I get the phone to thank the organizing committee and above all Dr. Muhammad Khalil who gave us this wonderful chance to be today. Pleasure being here. And I actually find this meeting very interesting. For those who stays until the last moment, please keep your phone off and try to listen. We have only one case left, and then we will all move. Okay? Just for the sake of the time, we'll proceed على طول for the speaker. The only speaker will be Dr. May, and she will present one of the cases in respiratory care. Dr. May is
Good evening, everyone. I know you're all tired. I'll only take no more than 7 to 10 minutes of your time. My name is May Ahmed Ali. I'm an assistant professor of anesthesia and surgical ICU. I need to present actually not one interesting case. This is a series of cases that we have, of patients that we have managed during the COVID pandemic, and we have performed a study, retrospective study, published as a letter to the editor in the anesthesia, critical care and pain medicine. This is why I'm so enthusiastic about lung ultrasound, because during the pandemic of COVID-19, we were in charge of an ICU for the patients with COVID-19 in Batna Hospital. And so, of course, as we all know, during the pandemic, we have shortage of ICU beds and shortage of ventilators. So it's very crucial to keep tracking patients, and there is an urgent need for successful and speedy weaning to keep places for other patients. COVID-19 patients have lots of comorbidities, so failure to disconnect the patient with subsequent reintubation will add to the patient risk and add to his mortality. So we are trying to look for other tools to help us follow up this patient without having to transfer them, because the logistics were very difficult during this period. So we used lung ultrasound to try to help us during the weaning of such patients. So we are testing the accuracy of lung ultrasound to measure diaphragmatic excursion to predict weaning, successful weaning in COVID-19 patients. Our primary outcome, this was our primary outcome. Secondary outcome included other respiratory parameters such as the respiratory rate, the PF ratio, the rapid shallow breathing index, the incidence of kidney injury, the use of vasopressors, Apache, and so forth. Of course, we included, as any patients going for weaning, we included those eligible for weaning, meaning that their primary chest condition has resolved, they have adequate cough, adequate conscious level, minimal secretions, stable vasopressor doses, stable blood gases. So whenever they meet all these criteria, together with the respiratory criteria, PF ratio more than 200, respiratory rate less than 30, then these are eligible for weaning and they enter into the study. We excluded any patient with diaphragmatic insult or recent surgeries, thoracic or abdominal. We scanned 22 patients having a severe COVID-19 who were invasively and mechanically ventilated for more than 2 days. These patients when they are eligible for weaning, they had a spontaneous breathing trial using pressure support ventilation with a pressure support of 5 and a peak of 5 centimeter water. The spontaneous breathing trial lasted for 2 hours. After extubated the patient during the spontaneous breathing trial, they have the lung ultrasound, and then they are followed up for 72 hours after extubation. They are divided into 2 groups, either those who succeed weaning or those who had re-intubation within the 72 hours or needed any further respiratory support, so this was considered failure. So they either disconnect from the ventilator and remain disconnected for 72 hours, these are the successful group, or they fail and need re-intubation or any support. So 9 patients were successfully weaned and 12 failed. During the spontaneous breathing trial, we applied a high frequency, 3 to 5 curvilinear probe to the lower spaces on the right side and on the left side.
Sorry, let me stop you here. هنا you wrote or you stated that weaning means that in the next 7 to 2 hours did not require any ventilatory support.
Successful weaning, yes.
Suppose that he needs a non-invasive ventilation or high flow that can be.
These patients that we were enrolled as successful, they only needed simple face or nasal masks. احنا simply ما كانش عندنا كمان high flow nasal cannula بتكفي كل العيانين في الكوفيد.
And that's my point. Sometimes you may have some ventilatory aids instead or to avoid reintubation.
These are failed weaning use. They are considered failed. The successful are the ones that may only need a simple supplemental face mask or nasal brush.
Even the other way around, failure is the need for intubation. Other than this, you not expect that the patient with a high flow nasal cannula is a failure.
لا حضرتك مش failure ده exclusion criteria عشان ما نقدرش نحكم على diaphragmatic excursion. This is an exclusion criteria, not failure weaning. They are excluded from evaluating their diaphragmatic excursion. They did not fail, دول عاشوا بروجرام بس هما we cannot judge the diaphragmatic excursion for such patient as an I can't recall right now لازم ارجع للاكسل شيت لكن لا some of them will need further non-invasive ventilation as maybe a high flow nasal cannula. Of course, some of them were reintubated and some others may have remained for some time with a non-invasive ventilation. ليه يا باشا لخبطت ليه؟ العين اللي هيبقى اكستوبيتد سالك 72 ساعة ده هقيسه diaphragmatic excursion.
Why you interrupt?
I feel weaning وانا اصلا الفيلير معناه reintubation which is not true.
محدش يقطع حد وهو بيقول محاضرة. احنا كده
The case
to understand what's
I manage this the way I can.
يعني but at the end of her presentation,
No, this is a case discussion.
You can discuss.
You cannot tell me what to do, please.
We fail to understand what you are talking about.
طيب احنا for a patient during measuring diaphragmatic excursion we applied a curvilinear probe over the anterior axillary line over the right spaces and some way between the anterior axillary and mid axillary line on the left side. Then we applied the M mode and freeze and then started measuring the thickness not the thickness, the displacement of the diaphragm during inspiration. So we measure the distance between the baseline and the highest point of diaphragmatic expansion as we can see on the screen. And this distance displaced by the diaphragm is known as the diaphragmatic excursion. So as we can see here, a patient who had successful weaning had significantly less age, less body mass index, of course less Apache score of admission, and less days of mechanical ventilation before weaning. They had as well a statistically significantly less rapid shallow breathing index. On the other hand, the PF ratio, which is logic, was statistically higher and the diaphragmatic excursion was statistically higher. For the successful weaning group, it was something between 20 and 28 millimeters on the right side, 17 to 24 on the left side. While those who failed the weaning according to our criteria, their diaphragmatic excursion was something between 8.5 and 10.5 millimeters on the right side, 5.5 to 8.5 on the left side. We looked further into some of the cutoff values for other outcomes of the study. So for the rapid shallow breathing index, we found a cutoff value of 97. For the PF ratio, the cutoff value of 281. And for the diaphragmatic excursion, it was 12 millimeters. So the primary outcome was the ability of the diaphragmatic excursion to predict successful weaning, and the area under the receiver operating curve was very nice. For the diaphragmatic expression, it was nearly 99% on the right side and 100% on the left side. So this was very nice. In such a critical situation, our study, to our knowledge at that time, was the first to evaluate the diaphragm for weaning in the COVID-19 patients. And we found that the diaphragm is very valuable to help us evaluate them for success of weaning, and a cutoff value of 12 millimeters never failed to predict successful weaning. That's it. Thank you so much.
Thank you very much. Next case. Anybody has any inquiry about this case? You can see that, of course, it helps, but the same extent. When it helps, it has to be combined with all other data that we used to do, clinical and bedside imaging data to show the distribution. In the definition of failure. This is what I need to clarify. Because if you consider using non-invasive as a symptom, it's not a failure of weaning actually. Especially during the era of COVID. And the era of COVID, we used the patient weeks or non-invasive ventilation of course.
Thank you very much for having me. My name is Prince Mohammed, and I'm the governor for Egypt for the American Association of Respiratory Care. And I'm also the CEO and founder of Respiratory Care Egypt, a place that we are proud to say that we are going to serve the best respiratory care practice in Egypt sooner. So I'm going to cut it short. I don't know why it's okay. So this presentation is actually by Karen Schell. Dr. Schell is the past president of the American Association for Respiratory Care, and she was my host in Kansas City when I was having my fellowship in respiratory therapy in the US. And I actually met her aside with Dr. Arsu here, or my dear friend here, and we actually plan to implement the respiratory care practice in Egypt in a manner that will have the best practice for Egypt. I know that this is a women talk everything, and we will present like just 15 minutes to cut it short, and I will speak everything about the case later, so it's going to be like maximum 17 to 15 to 20 minutes. And I don't know why it's so working. So this case is actually the studies under the name of One Patient Can Make a Difference. We're not going to get into the clinical background, and it's not a boring lecture. However, it's going to say how respiratory care practice managed to, let's say, getting better outcomes from our patients. And Dr. Schell is a pioneer in respiratory care in the US, and we work together. And this patient for her is very special. That's why she had decided that she's going to present this patient. And I'm just going to need you to hear from her the first 5 minutes to know the patient from her perspective, and then I will proceed after that. And sorry for the technical issue again. Okay, so I'm going to speak about the patient till the issue is being resolved. So this is a 53 years old female patient, and this patient goes back to the 1984. And yes, it doesn't have this kind of clinical stuff and everything, so everyone is going to know like the guidelines in management this patient. However, this patient was very special to Dr. Schell because Dr. Schell was the one who got the chest wall oscillator to get covered by Medicare in the US. And because of her, now we have multiple devices of chest wall oscillator, and she's going to speak about how the pulmonary rehabilitation and secretions management in the ICU and outside the ICU can aid our ICUs in the length of stay and to get better management and patient-centered care with protocolized management for our patients. And to be honest, till this session starts, I'm going to take the opportunity and seize it. We know that this word is... Okay. Okay, so I'm going to take the opportunity while the video is on. How many of you professors have implemented respiratory care practice in their ICU? Like a real respiratory care practice, starting from the management of aerosol therapies, that you can bypass the things that Dr. Arzu is speaking here about by implementing someone who can manage this properly and elevate the burden over the healthcare inside the ICU. It's a multidisciplinary thing, and we work all together, and I'm really, let's say, passionate about my profession. I love my profession, and being a respiratory therapist is hopefully is going to change a lot of patient management in our ICUs. So, to be honest, we need all of you to rethink about having respiratory therapists in your ICUs. Here it is. Yes. Okay. This is a technical issue, and we're very sorry for that. However, I think we're gonna. Okay. So, out of the experience of the case she was going to speak about, it's how creating a multidisciplinary approach to our patients can aid our ICUs to get the length of stay lower and get the best practice for our patients in all the ICUs. I know it's a lot of things we need to do, cost-effective approach, a lot of management, patient-centered care, and not all of the places that can implement respiratory care practice because it's kind of expensive. However, if we're gonna take a look into the other hand, look how this is going to save you money, like a lot of money in your ICUs. Because I'm going to give you a small example, and I'm going to finish after that, how Dr. Arzu spoke about how the aerosol therapy management in the ICUs is very crucial. Speaking of the jet nebulizer in our ICUs, how many of you write Pulmicort and Atroban TID for our patients without hearing them every 2 hours? All of them. Because it's like a standard of practice for our patients. Just give them that. Okay, who is going to implement the service to our patients? Okay, mostly nursing. A population has a lot of burden in the ICU to take a look to. So they just go to the flow meter and, 15 liters. 15 liters. Flow rate, higher flow rate, decrease in the, as Dr. Arzu, decrease in the deposition. So we are giving the patients nothing. So when we are going, that's it. So we are giving our patients nothing, because if we're speaking about aerosol therapy, 3 milliliters of the aerosol we're putting in the jet nebulizer, and then we start nebulizing it to still like in the residues. So we have 1 centimeter of medications when we don't know how, like the particle size of this medication, because it's on 15 liters. So speaking of dilution, yes, we need to dilute. All of the things, we have a small calculation for how we're going to save money just by implementing the right aerosol therapy to our patients. Speaking of getting this 15 liters to 10 liters can get in saving, even a patient in an ICU with 50 patients can save 700,000 liters of oxygen a month. This is big. 7,000 liters for a mean 50 patients ICU. This is like, if we're speaking of H cylinders, we're speaking of 16,000 liters of oxygen in each bed. So wow, this is a lot. Just by getting this 15 liters down to 10 liters. I'm not going to delve into the mesh nebulization and how the mesh nebulizer can be cost effective and everything other than that. But imagine that you have a service in your ICU that can elevate your patient care, can elevate how you approach your patients, and you get better results for your patients. And we're doing this as respiratory therapists. Yes, we have a small community of RTs. However, they are getting bigger. We are having now, in the next 3 years, we're having more than 5,000 RT in Egypt. 5,000 RT. We're speaking of a ratio of 1 to 7 patients. Imagine how many of your patients you can add service that you don't know that it can help your patient get better.
Wallah, you are right here, Dr. Marzi. I totally agree with you. if you stand here the rest of the night explaining or showing how much the RT is adding to our practice, or adding to our practice in the ICU, you may not finish. You just mention very little what they can do. And actually, we were very lucky being part of the School of Sheikh Qatar, the first to take care of the big hospital in Egypt, like Dar al-Kuwait or Salam al-Dawi. We understand these facts since 2000, the beginning of this century. We are now a quarter of century working with our colleagues from the respiratory therapists. And when we move to Gulf area, we find this very easy and we understand. The communication here needs an education for physicians to see how they are helping to give them the trust. They are now educated not like before. Before, at the beginning of the century, we used to train them ourselves by our education. Remember Nasser, the first binder, he was not actually an artist. But now we have another complementary team. I agree with you 100%. I hope very much for this. That's why
and I'm very happy to help in any of your ICUs who have a big team. Please say, hey, if you're an RT, here are all of those. We have like 50 back there. So they are all up and running for your ICUs.
Okay, and from my side, I will arrange, and one of you guys listening to this recording, might like 3 months or so training in our ICU. And I suggested to speak with Dr. Rashidin, Dr. Ali afterward. We can arrange for them something like
if I'm not in the release.
Thank you very much, Muaz. And I remember في جامعة مصر كانت الدكتورة فوزية مفتوح حاجة؟ الدكتورة فوزية مفتوح كانت عملت conference for the respiratory therapists. And I had the honor to be one of the speakers. And I think the problem here is the job description shall be clear through the Ministry of Health. وبرضه من خلال نقابة الأطباء هم I don't know يعني هم following أي نقابة.
Sorry. No, not in the meantime.
So they need to have like a host.
However, I'm gonna cut you. I'm sorry for that, but right now we have the registry. We all registered at the moment. All the RTs in Egypt are registered at the Ministry of Health. We have a license for respiratory therapy, and I think for the time being we have not that much number that I can go to the Ministry of Health and say, all right, hello everyone, I need to put a job description for 500 people I have with me. There is something in there, but it's not just active. However, we could just set with every committee in any ICU, we can tailor our protocols. I can give you the protocols we are working. We are taking our protocols from the IRS and the ICRC and the ARC. We are working together to help them. I think this is my job description for the ARC as a governor for Egypt, to help making this happen.
بحاول أساعدك.
Yes, please.
أنا بحاول أساعدك في حاجة مهمة جدا. إن معظم الانتنسيفست I know that worldwide. معظم الانتنسيفست this branch is relatively new in Egypt. And you need to spread more the word. Same like the clinical pharmacy. As we started, similarly we started training the clinical pharmacy and there was no clinical pharmacy. Now we have clinical pharmacy in the hospital. The problem was the RT, that they needed like an association. They can follow for example, ممكن تقعد مع رقيب الأطباء. For example, and يبقى في like an association or working or something that can educate and can spread the word about the job of the RT I know aerosol management, most of the ICUs are giving this to nurses. They don't realize, most of people do not realize the difference between the management. If a respiratory, I know that, not me. For example, my colleagues. The difference between your practice and their practice. RT in United States is very long time. When I stayed in the United States, the whole ventilation process is with the respiratory therapist. When a patient is going to be ventilated, the respiratory therapist carries the ventilator from A to Z.
We do that here.
Okay? But this is not the current practice. And that's what I want to comment about you.
Thank you very much, Dr. Akram.
We have we will be to help them. It will not come from their side. We have to control them. It's a new, as you say. And that's one we are at least arrange this will be a privilege for us. أنا will arrange this with دكتورة شيرين دكتورة عالية نتكلم في القصة دي لو عندهم استعداد إن هم يجوا روتيشن عندنا. This is our privilege. يلا.
Actually, Dr. Akram, we will be more than happy to set the setting medical syndicate with anyone that can help this profession grow. And as the ICU started back with Dr. Sharif back in the 80s, this is a medical profession that can grow and can help the patient eventually. Thank you very much for having me.
I thank the organizing committee for this beautiful day, and let us go for lunch. Thank you.